The following presentation will describe the integrated trauma treatment approach that will combine EMDR and REBT treatment approaches. It will also present a Christian worldview. So the objectives that will be covered during this presentation will be to understand the application of eye movement desensitization and reprocessing therapy, understand rational emotive behavior therapy, apply the integrated approaches for the treatment of trauma, and understand a Christian worldview. EMDR, eye movement desensitization and reprocessing therapy, is an empirically approved treatment for distressing traumatic events that are stored maladaptively in the brain and body. EMDR is a holistic approach that focuses on emotions, thoughts, physical sensations, attitudes, behaviors, and more. The traumatic experience does not have to be described in detail, as the experience is processed on a physiological level known as a bottom-up approach. EMDR is touted as an integrated treatment approach and is again considered a bottom-up approach that accesses the limbic system that regulates emotion. EMDR was discovered by Francine Shapiro, a doctoral candidate, in 1987. Francine Shapiro discovered that while she was walking, she noticed that when her eyes moved back and forth, that the thoughts that were causing some anxiety became less distressing. This initial experience of the correlation of reduction of stress and eye movement formed the basis for her doctoral dissertation in clinical psychology and the beginning of EMDR. Adaptive information processing theory was developed in 1991 by Francine Shapiro to support EMDR's method of healing trauma. It provides a theory of how the brain processes and stores memory while using bilateral stimulation. This model theorizes that traumatic memories are incorrectly stored and become barriers in processing and storing memories correctly. The negative or traumatic experience overwhelms the information processing system of the brain. The experience goes unresolved and the memory is incorrectly stored, causing the trauma to be re-experienced over and over. Specific technique of EMDR is the use of bilateral stimulation through various means such as tactile, auditory, and visual back and forth movements. The bilateral movement of side to side affects both sides of the brain, supporting the integration of distressing experiences by activating the brain's natural adaptive processes, and then the memories can be stored correctly. Rapid eye movement, or REM sleep, is where emotional memories are processed and then stored, and is referred to as the paradoxical sleep because the brain is active but the body is at rest. It can be surmised that the eye movements in EMDR reopen a crucial window or REM-like activity needed for integration and learning to take place. There are 8 phases of the EMDR treatment approach. All phases are an important aspect of treatment, and if a phase is removed, it cannot be classified as EMDR therapy. There are 8 phases of the EMDR therapy process. They include client history, preparation, assessment, desensitization, installation, body scan, closure, and reevaluation. The next set of slides will define these 8 steps of the process. Phase 1 involves getting historical information from the client and establishing a treatment plan. The clinician at this phase will determine if EMDR is a good fit. It is at this point, or this phase, that the clinician and client decide the treatment targets. The therapist during this phase determines past, current, and future experiences that are causing the most distress. This is referred to as the 3-pronged protocol. During phase 1, the therapist will establish trust for effective application of EMDR, and this can be accomplished by providing thorough answers to the client's questions at the onset of treatment. In phase 2, named preparation, the client is introduced to EMDR and prepared for the processing of the targeted event. The therapist will complete the following tasks during the second phase: educating a client on what to expect during and after treatment, build confidence and trust in the therapist and the process, continuous informed consent throughout treatment, and teach coping skills to include safe or calm space, containment, and relaxation. During the second phase of treatment, the clinician will teach calming techniques such as safe space or container. These techniques enable the client to decompress and calm themselves down during and outside of session. The demonstration of the container exercise performed by Dr. Merrick can be found at the link to the left of the slide. During the assessment phase, the clinician will identify relevant information for each target identified memory that will be targeted and activated during reprocessing. Prior to reprocessing, the therapist will complete two important tasks: identify the critical core components of each target memory and obtain baseline measures for each target memory. In phase 3, the client will be required to select an image that represents the distressful memory. The client will then be requested to select a negative thought related to that distressful memory. And examples of those negative associations are I am not worthy and I am bad. During phase 3, the client is asked to pick a positive self-statement to counter the negative self-statement, which is considered cognitive interweave. Once the statement is identified, the therapist will ask the client to rate the belief on how valid she believes it is on the validity of cognition scale. The scale rating is from 1 to 7. The client will also be asked to rate the distress of the memory using the subjective units of disturbance scale, the SUD. This scale measures from 0 to 10, whereas 0 represents no distress at all and 10 considered great distress. Once the SUD score has been established, the clinician will immediately ask the client where they felt it, emotions, feelings, and physical sensations in their body. This assists the client in making the connection between emotion and somatic experiencing. Moving on to phase 4, named desensitization, this phase begins the bilateral integration using eye, auditory, or tactile movements. The goal of this phase is to reduce the SUD scale identified in phase 3 related to the traumatic or distressful memory. So a sample dialogue related to desensitization is as follows. Now remember, it is your brain that is doing the healing, and you are the one in control. I will ask you to mentally focus on the target and follow my finger with your eyes. Just let whatever happens, happen, and we will talk at the end of the set. Just tell me what comes up and don't discard anything as unimportant. Any new information that comes to mind is connected in some way. If you want to stop, just raise your hand. Moving on to phase 5, named installation, the goal of this phase is to fully enforce the positive statement or belief surrounding the disturbing event. Instead of believing I am powerless because of what happened, the client will be encouraged to state the positive statement. Then it is reinforced through bilateral stimulation. This is measured by the validity of cognition scale. Phase 7 is named closure. This phase is used to evaluate the client's well-being at the end of each session, as well as continuing to educate the client on calming techniques while providing psychoeducation on journaling in between sessions of any of negative or even positive experiences. Finally, phase 8 is called reevaluation. It occurs at the beginning of each session after the first one has been completed. The therapist monitors the progress of the patient using the SUD and VOC scales, as well as any mention of physical experiences. This phase will also recognize and track any new targets. Each phase completion is dependent upon the client. Trust is crucial and may take time, so it may take longer to get through certain phases. There is no time limit on these phases. Each phase must be completed in its entirety to ensure the client receives the maximum therapeutic benefit. Now we'll be moving on to rational emotive behavior therapy, which is the therapy of choice. It was created in the 1960s as rational emotive therapy by Albert Ellis. The approach later evolved in 1993 to rational emotive behavior therapy. Ellis's work is influenced by Buddhist philosophy as well as Greek and Roman philosophers and Stoic philosophy, which includes the handiworks of Epicurus, Epictetus, and Marcus Aurelius. RBT is a cognitive and behavioral approach to treatment and has been empirically proven to reduce various negative behavioral and emotional symptoms and is well suited to treat the symptoms of PTSD. REBT is a multimodal approach that can be used with other types of therapy. REBT posits that it is not the action or event that is disturbing, but how one views the event. Thinking in irrational ways to activating events create unhealthy and debilitating emotions. Unhealthy negative emotions are described as anxiety, panic, extreme fear, depression, despondency, hopelessness, rage, shame, and guilt. These negative emotions can be created due to traumatic or distressful events. REBT's irrational thinking basically indicates that the rational thinking that disturbs the emotions and affects behavior are as follows: the demands, the shoulds, the musts and oughts, rigid thinking, blowing things out of proportion and lack of realistic perspectives, catastrophizing and awfulizing, overgeneralization, absolute thinking and stereotyping, low frustration tolerance, as in I can't stand it, damning oneself and others and life when things do not go the way one thinks they should. Implementing the tools of REBT can be completed using cognitive, ABCDE approach, emotive, imagery, and behaviorally exposure. So REBT's cognitive approach uses the acronym ABCDE. A stands for the activating event. The client will describe the event that is causing the distress. B is the belief about the event. The client will then identify any irrational beliefs that occurred because of the event. The consequences or emotion or behavior describe the unhealthy negative emotions and behavior that occurred because of the rational beliefs presented. D is disputing. The client is assisted in disputing the irrational or unhelpful thought through realistic and logical evaluation. E is for effective new philosophies. Identify new helpful thoughts and behaviors and alternatives that can replace the original irrational belief. REBT's emotive imagery encourages the client to imagine the distressing situation, then stay in that moment and challenge the irrational thoughts and emotions. While in this active state, the client is encouraged to establish and repeat strong, positive coping statements. REBT's behavioral aspect. The client is encouraged to remain as long as possible via in vivo desensitization when it is safe to do so, and basically remain in the difficult thought and emotion to develop frustration tolerance of that event. Integration of REBT and EMDR. As indicated earlier, one therapeutic practice of REBT is to desensitize clients to distressing thoughts and emotions. This is accomplished through staying in the distressing memory through imagery while repeating a coping statement until the thought has been tolerated. EMDR 2 focuses on imagery of the traumatic or distressing event while using bilateral stimulation to process the traumatic memory. Whereas REBT uses desensitization and positive reinforcement to reduce the negative beliefs and emotions and is a top-down approach, EMDR uses a more physical approach of bottom-up. Using REBT's principles of irrational thoughts, the client can be encouraged to recall their negative or irrational beliefs and then requested to identify an opposite, more realistic belief. Once completed, these beliefs can be rated on the VOC scale and then use bilateral stimulation to incorporate the new, healthier belief. EMDR has been utilized globally and has been adapted and embraced by many cultures. Visualization used in EMDR and REBT is an effective therapeutic technique to increase comfort and increase distress tolerance. EMDR can incorporate Christian values in two ways, through visualization and positive statements. Visualization of spiritual truth, such as biblical passages, can provide more healing and comfort than words alone. Clients can visualize the image of Christ or the Lord's presence, as well as focus on Bible verses such as Isaiah 41:10. So do not fear, for I am with you. Do not be dismayed, for I am your God. I will strengthen you and help you. I will uphold you with my righteous right hand. The client can be encouraged to focus and meditate on Christ-like imagery and passages during and after sessions and journal to determine the impact. Prayer is a meditative practice among Christians which connects them with God and as a result finds peace, comfort, and discernment. Using prayer as a meditative practice before the start of each EMDR session can provide a sense of safety and comfort, not only for the client, but for the therapist. Prayer may change the whole outlook of therapy because it brings a transcendental element or a transcendental reality to therapy. So, as we conclude the presentation, I want to leave you with a few concepts. EMDR is an effective and empirically studied treatment approach for trauma and other disorders such as anxiety, depression, and addiction. It is also adaptable and can be combined with other therapeutic approaches such as RABT. EMDR is practiced among different cultures and can be utilized with those that have different religious beliefs, especially Christians.